Hello and welcome. And today I'm very pleased to introduce Dr. Neil Baum, who is the co-author of the very, I want to say very interesting because it is very interesting, but it's a really good read as well. A book about prostate cancer, and it's called Expert Advice for Helping Your Loved Ones. And this, I don't know, Neil, I did read quite a lot of it because I actually got engrossed in reading about it, because the way in which you and your co-authors write is just in such an easy, informative way, and I can really understand its appeal, which is obviously what it's all about, is for the other person's loved one to understand about the subject. So before I waffle on any further, Neil, please could you introduce yourself to everybody?
I am a urologist that is a physician that takes care of the prostate gland. And I have been in practice 44 years and have cared for thousands of men. And I've cared for the men and their partners. And I want to emphasize that so much during our discussion. I'm also in academic medicine at Tulane Medical School, and I have enjoyed writing, and particularly have enjoyed writing to non-medical audiences. And that's what this book has done, that we have created a communication with viewers or readers who are going to understand the concept of prostate cancer, which is one of the most common cancers in men and is the second cause of death in men following lung cancer. But we've made it such that the partner can now be part and parcel of the team and can be supportive of the man who has this disease. I'd like to perhaps begin by telling you how I embarked on writing this book.
Please do.
My wife had breast cancer, and I used to accompany her to her doctor. And one time I was sitting in the reception area. By the way, we don't say waiting room anymore. Now we use the word reception area. I was in the reception area of her surgeon, and I see a book entitled Breast Cancer for Men. And I think to myself, you know, I know a lot about breast cancer. I'm a physician, and I opened it up, and I see that there were many topics in there that were way over my head and that I wasn't knowledgeable about. So that was a light switch for me. And I said, I wonder if there's anything available for partners of men who have prostate cancer. And I did research. It took me several weeks to do the research. I found there was nothing. And so I created a book proposal very similar to that book that was written for men who have partners with breast cancer. And I submitted it to a publisher. I'm very proud of the publisher. Johns Hopkins Press is one of the foremost medical publishers. And they accepted the concept of the book. I teamed up with a fellow urologist from the Baylor College of Medicine, Dr. David Mobley, and a psychiatrist, Dr. Richard Garrett, who's an academic psychiatrist at the University of Texas. And the reason I wanted a psychiatrist, because there's such an emotional component to the concept of prostate cancer. And I hope we'll have a chance to discuss that. So I teamed up with another urologist who deals primarily with prostate cancer, and the psychiatrist, to put a book together without medical jargon. I wanted it to be something that would be easily understood by anyone who gets the book, who reads the book, and who would get a greater understanding of the problem of prostate cancer and would be able to use that book to craft questions that the man and the partner should have when they go to communicate with their physician. And I have found by giving out this book to partners whose their partners have men with prostate cancer, that their understanding has blossomed and bloomed, and they are now part of the team. And I think with any kind of disease, even if it's not cancer, it could be heart disease, pulmonary disease, any chronic disease, diabetes. If the more involved the couple is, the better that the one who has the disease does. And I think this is very important. And that was a goal or objective right from the get-go of embarking on writing this book. I also want to mention that anybody who says, oh, I have a good idea, I'd like to write a book, I want to tell you it takes about a year or 18 months from the time that you have that idea and the time that that book gets to the publisher. To put this in perspective, it's twice as long as it is to have a baby. That's how long it takes to create a book. But I'm so glad I did. It was worth the energy and the effort. But it's not something that you take a shower, you have an epiphany, you dry off, and you have a book. It doesn't happen that way.
No.
But that's a little bit about the origin of how I came up with this book. And that has been the response that I have from partners who have had the opportunity of reading the book.
I think, having read through the book is that it allows you to be involved with your partner because you can understand what is going on, and it steps you all the way through with asking questions that you can ask your questions as a couple to each other, which actually then allows the involvement, as opposed to just saying, well, what did the doctor say? You can go to the doctor informed in knowing what to ask without feeling, because there's always that concern that when you ask the doctor, am I asking a really stupid question? Is this something that I should know already? And as you know, you go to a doctor and quite often, as they start talking to you and it's sort of in one ear and out the other ear as quickly as it's managed to go through to compute it. So I think that's what's so good about the book, is that it does allow you to step through things in a sort of a slow way for you to really understand it in what it will mean to both of you and your partner's life as you go through this. And that's what I think is excellent about it. Now, we discussed that that there is so much in this book as to where on earth could we sort of start and what bits. And so I asked you, what were a couple of areas that you would like to discuss in particular? And the first one that you came up with, which I think is a very, very good starting point, is the screening stage.
Men can get screened for prostate cancer by a very simple blood test called PSA, prostate-specific antigen. And this test is a blood test that picks up the chemicals that are the antigens that are in the bloodstream of men with prostate cancer. It's not a specific test. It doesn't confirm the diagnosis of cancer, but it gives the doctor and the patient and the partner information that a man may have prostate cancer, and additional testing is usually required. I recommend that all men over the age of 50 and men who have a brother, uncle, or close relative with prostate cancer, because there is a genetic predisposition for prostate cancer, start to get screened if you have a relative or African American, and you start the screening process after the age of 40. But for all other men after the age of 50, and they can probably stop at the age of 75. Why can they stop? A man who has prostate cancer at age 75 is probably going to succumb to something else, heart disease, diabetes, pulmonary disease, and not prostate cancer. Prostate cancer is a very slow growing cancer, and therefore it really probably doesn't require treatment after the age of 75. The other recommendation is that if a man has a life expectancy of less than 10 years, probably there's no reason to proceed with screening for prostate cancer. So if a man has another cancer or has diabetes or has renal failure and is on dialysis, that man probably doesn't have a life expectancy beyond 10 years, and that screening is not important. Now, the reason I think that men need to be screened is, if you were to ask me, Neil, what are the early symptoms of prostate cancer? If there's one thing that I hope that I get across in this interview, is that there are absolutely no symptoms of early prostate cancer. By the time that there's blood in the urine, by the time that there is bone pain, by the time the disease has spread that is causing symptoms, that's when prostate cancer can't be cured. On the other hand, if it's detected early, when it's confined to this walnut-sized organ, about the size of a walnut, that's about the size of the prostate gland. That gland, which is a source of enjoyment and pleasure and responsible for being able to father a child, causes lots of problems when a man gets older. But early prostate cancer has no symptoms. That's why I think it is imperative that the patient and the partner have a discussion with the doctor and make a decision whether screening is appropriate. Women get screened after age 40 for breast cancer with mammography. Men and women get screened with stool testing and colonoscopy for colon cancer. This is a condition that requires proper evaluation and screening and detection when the disease is confined to the prostate. After it's beyond the prostate, cure is not possible. Control is possible, but not cure. So for that reason, I hope the listening audience gets the message that early prostate cancer has no symptoms. If you wait until you have difficulty with urination, or you have blood in the urine, or you have spread beyond the confines of the prostate gland, it's too late. Can't be cured.
We have over here, sometimes having a PSA test is met with controversy, because quite often people say, well, it isn't always reliable. So what would you suggest if is it possible for the PSA test to come back and it's all, negative, i.e. there is no signs of cancer, but there could be? Is that possible?
That's possible. What usually happens, that's possible, not likely. What usually happens is the test comes back positive and they don't have cancer. There are many other situations that can cause an elevation of the PSA. And that's why additional evaluation, or even just repeating the test in 3 to 6 months. And if it's creeping up, that's a big indication that there may be lurking prostate cancer. So it's much more common that the PSA rises and they don't have prostate cancer. But it does create a tremendous amount of anxiety to a man and the partner when they get that test back. If it's positive, then they have to get additional testing, to prove yes or no that they have prostate cancer.
But I mean, the positive thing is that once you know that there is a possibility, there's a lot of further things that one can look at, and whether it be just checking to see if something, I think you called it the other day when we spoke, was it silent watching?
Oh, watchful waiting.
That's it. Watchful waiting. That's
yes.
it.
Yes. It is not uncommon for a young man who is, we're going to talk about side effects, I hope.
Yes, we are.
Not uncommon for a young man who is sexually active who says, I'm not sure I want to undergo treatment and risk, my losing my manhood and my ability to engage in sexual intimacy. And he decides, with the oversight of the urologist, of the doctor, why don't we wait? Why don't we repeat the test in 3 to 6 months? Why don't we wait till we get a biopsy before we embark on treatment? So yes, watchful waiting, it's called watchful waiting or active surveillance. But this mandates that the patient be diligent and come back regularly for follow-up examinations. It's imperative if they take that route, which is okay. I have had lots of patients that have done this, and the PSA just stays stable, minimally elevated, not escalating. And other than the anxiety of having to go back and get the test frequently, it is a viable treatment option.
So, well, let's move into the complications, because I know that is definitely one of the areas, because I think a lot of people, and from my own experience, of a lot of men aren't keen to actually go and take the test because they just hear about all the complications that can happen. And, I think it's important to understand what those complications are and maybe take some of the fear out of it.
Okay. I think that's a good next point of departure. The complications from surgical removal of the prostate gland, and this can be done through what's called robotic surgery, where little tiny holes are made in the abdomen, and the doctor goes in with scopes or instruments that allow visualization inside the abdomen, and they can remove the prostate without making a big incision. Okay, so there's less discomfort afterwards. There's more prompt healing because there's not a big decision. But with the removal of the prostate gland, there are nerves that go, if this is the prostate gland, there are nerves that go along the side, each side of the prostate gland. And when the gland is removed, those nerves that go to the penis that are responsible for erection can be injured or can be divided if they have to get out the prostate gland and the tumor is spread near the periphery of the prostate gland, and it can result in decreased erections or erections that require medications or injections, to resolve. The other complication, the problem with erection problems occur in about 30 or 40% of men who have the surgical removal of the prostate gland.
Wow, that high.
Now, yeah, very high. And especially imagine, any man, you take an erection away from any man, his sense of his masculinity and his manhood collapses. And that is really devastating, so therefore they're hesitant to have the gland removed. Now, there are other options available, such as radiation, which doesn't remove the gland, and it can be very specific, radiation that, doesn't get near the nerves. But again, even with radiation therapy, there can be problems with erections, and the man needs to have the medication. Now, there's other treatments now called HIFU, high intensity focused ultrasound. This is like a laser scalpel. It uses high energy to destroy the tumor inside the prostate, and that results in less problem of impotence. The other problem of significance that occurs is probably even more devastating than the erection problem is urinary incontinence, the loss of urine. Normally, after you're a toddler at age 2 to 3, you can control your urine until much later in life when you might have urinary problems, and when a man is much older. But for a man in his 50s, 60s, or 70s to lose urine and have to wear a diaper, this is the most devastating complication associated with surgical removal. The reason is that the muscle that keeps the urine in place until the man normally goes to the restroom. I often describe the bladder and the tube that goes to the outside of the body as a balloon. Balloon represents the bladder, and the stem of the balloon represents the tube that goes to the outside of the body, called the urethra, urethra. And there's a muscle right at the stem of the balloon that opens up and allows urine to flow outside of the body, and then it closes, and then it keeps the urine inside the body till the next time that the man has to go to the bathroom. So during surgery, that muscle can be injured, and the man can be left with incontinence. And this is a devastating problem. The man becomes reclusive, doesn't want to socialize, doesn't want to have even hugging and social intimacy without intercourse with the partner. It is truly a very sad state of affairs, but it can be helped. There are things that can be done requiring additional surgery, the use of the diapers, so the use of a catheter, but these are not very welcome types of options, for a man. It doesn't happen. Incontinence does not happen with radiation. It is rare with HIFU, and it is about 5 to 7% of men who have surgical removal of the prostate gland. So these are the two major complications that every man has to understand before he embarks on a surgical removal of the prostate gland.
In our country, I know that the first option generally offered is just full removal of the prostate gland, as opposed to radiation or HIFU treatment. Is that for any particular reason, or is it because they're newer inventions and there's less expertise around?
Medicine, unfortunately, has a status quo, and it's, what has been learned through our training and medical school becomes so embedded that any new ideas aren't readily accepted. And I can give you multiple examples that a new idea that comes in, new idea that is brought out is not universally accepted. if I came out and said I have a cure for prostate cancer, people would, throw out the idea. I would be, embarrassed and, lose my respect within the medical community. We don't accept new ideas readily. And so here we do have other ideas, other options that are available. I mean, I think in my lifetime, we're going to get a vaccine for prostate cancer. When that vaccine is on the marketplace, there are going to be naysayers come out of the woodwork and say, nah, that doesn't work. Hadn't served the test of time. It hasn't, it's not viable. We need to do more studies, and as a result, you're going to find, pharmaceutical companies and device companies not eager to, bring new products and new drugs and new ideas onto the market because of the difficulty getting the medical establishment. In other words, let's give you an example. If I said to a man, okay, I'm going to remove your prostate gland, there's a 40% chance, surgical removal of the prostate gland, 40% likelihood of impotence, and a 5 to 7% that you'll permanently lose your urine. Or if I said there is this, there's radiation and there's HIFU, HIFU does require an anesthetic, but no incision. The likelihood of impotence is very low, and the likelihood of incontinence is almost is absolutely rare. What would you like, sir? 100%, not 99.9. 100% say, I think I'd go for the conservative, less complication procedure, and yet it hasn't reached critical mass of numbers of patients who embark on it. I hope that this book, educates men so they can go to the doctor and say, well, you suggested removal of my prostate gland. What about A, B, C? What about doing nothing? And now, the doctor has to pull back, have a discussion with the patient and the partner. And that's why the partner is, really should be actively involved, especially with the issue of sexual intimacy. They're part and parcel of the equation. And therefore, I think this book is going to hopefully, is going to enlighten the man and the partner as well. If I were advising a man who has all his studies say he has localized prostate cancer, he's sexually, active, and he goes to the doctor, and the doctor says, no, the only treatment for you, the only way you're going to get a cure to this is surgical removal. I'd say, get another opinion, sir.
Yeah. No, that's really good.
I hope this book, sheds light on that, and that there are options. And when you go to the doctor and the doctor gives you one option, no, that's not the case here. There are multiple options. And I can tell you, if when men are given an option, they want the more conservative one that preserves their intimacy and won't make them what I call a urologic cripple when they can't control their urine.
Yeah. And I presume that if you go down the radiation or the HIFU road and you find that hasn't worked for you, you can still go on to have a full prostate removal.
It's especially after radiation, it is more difficult. And if you were to try to remove the prostate gland after radiation, the likelihood of incontinence is very high, because the surgical planes are blurred, with radiation. There's scarring that takes place. You can't identify where the nerves are. So yes, there are things that can be done, but usually you don't go back and say, okay, if we can't control it with HIFU, we'll remove your prostate. It's usually not done. There are other things that can be done, and that's outlined in the book as well.
Right. Okay. So yes, so what we're saying is go for the less invasive to start with as an option, or see what options that are available.
I, being a man and who has a partner, I know that this is what I would want for me. And therefore it's very easy for me to say that to a man. I don't believe one size fits all. No. And the healthcare profession needs to embrace new ideas and new lines of thinking. Who would have thought that one of the options for treating and managing stress, depression would be mindfulness and meditation? But this has come on in the last, I would say, 10 or 15 years. And now we recognize that this is, a non-medicinal, non-medical, non-pharmacologic approach, and just learning to control your breath, learning how to remove stress in your life can reduce the amount of anxiety and even depression. Now, this is well documented, but who would ever have thought that 15, 20 years ago? You'd have been tossed out.
You would. So on a last note, just to round up and quickly, because we said that we'd mention it if we have enough time. So very quickly, and I think you've actually emphasized the point as we've been going through, is about the emotional side and the emotional journey, although I don't like that word journey, but it is an emotional journey from the beginning, from diagnosis all the way through to having the operation, coming out the other end, then waiting to find out if it has been a success. And I think that's what you were trying to stress, is that it is a very important part in the whole journey.
Absolutely. When a man has to go get that test or make an appointment with the doctor, men don't like to go to the doctor.
No.
Women start out, from the time that they're in their 20s and they start having children, they see a gynecologist and they're very comfortable with an examination, with a mammogram, and they, are very comfortable in the healthcare profession. There's a hiatus from the time a boy finishes with his pediatrician, say 17 or 18, until he's in his 50s, that he doesn't go to a doctor. And consequently, the going to the doctor is fearful and produces anxiety, and having to go get that blood test on a regular basis escalates the anxiety. And that's why I think it's important that we understand the emotional component of what these men go through and how the partner can help ameliorate or help reduce that tension, that pressure, and that anxiety. And so I think partner involvement is critical to the management of prostate cancer and many other, not just that condition, but I think my wife was very appreciative that I attended all of her meetings with the doctor, and I had my questions, and I was welcomed by the doctor. It wasn't an uncomfortable situation. We weren't challenging him. We just wanted information. My wife was really appreciative of my participation. And I think any man who has prostate cancer and a loving, caring, compassionate, empathetic partner will appreciate, and their love will get stronger.
But I also think that your book, if the man decides that he wants to do this on his own, because he can do it, I think this book is very helpful for the partner to read, for her to understand if the man isn't communicating what's going on, that you at least know what is going on, so that you can support him as and when he might suddenly go, I do need support, or perhaps hasn't realised he needs support, and you can offer it at that point.
Absolutely. You know, it's of interest to me that prostate cancer is a disease of the couple. The couple is involved, and the more involved the couple is, the better he does, the better outcome he has, and his quality of life picks up, you know, when the couple is involved. And I think that's a real take home message. So if I have to conclude here with take home messages, number one, prostate cancer has early prostate cancer has no symptoms. Men after the age of 50 should be tested. Second of all, help is available. Number three, there are options involved. It isn't one size fits all. And number four, involve your partner. For the man, it'll make all the difference in the world. I didn't say you'll sail through this, but I'll say that the seas won't be as choppy as when you try to go it alone. And so, men, share with your partner, encourage her to read the book, you read the book with them, and I think it will be a better journey for both of you.
Thank you. And I think that's very, very wise words. So thank you very much, Dr. Baum. Thank you, everyone.
I enjoyed the interview. Thank you.